All right, so this week we're going to start with endocrinology. And again, just to review that we're doing I'm focusing on the NCCPA blueprint topics for the PANCE. This is going to help you for your EORs, for the PANCE, for your exams, and hitting the most high yield topics and focusing on the most important parts of those topics just to get you a better idea. I'm going to give you some important ways that you can remember and tips that I used when I was in PA school to really cement this stuff into my brain and not forget it. So let's get started on endocrinology, and this is 7% of your PANCE. We'll start with chronic adrenocortical insufficiency. So this is when the adrenal gland is not producing enough hormones. So there's two different forms. There's primary, that's the one that most of us know the best, and that's Addison's, and that's when the adrenal gland is failing. And then there's secondary, where so the pituitary is failing to produce ACTH or enough ACTH. And the way I remember that Addison's is related to adrenal gland failure is just because Addison starts with an A, so it makes me think of adrenal gland failure. And then secondary is your pituitary not producing enough ACTH. So in primary Addison's disease, there's a few things you should know about this. In Addison's disease or primary, there's a lack of both cortisol and aldosterone, because remember the adrenal gland's not working properly, so you're having different hormones that are failing in the situation. So lack of both cortisol and aldosterone. It can be caused from a number of different things. If we're talking about the United States, the most common cause is an autoimmune destruction. In other parts, in developing countries, the most common cause is going to be infections like TB, HIV. It can also be caused from some medications. The one that you really should remember is ketoconazole, also rifampin, but really remember ketoconazole. That's one of the ones that I've seen on a lot of exams, and that seems like to be one of the favorites. So this is a way I remembered some of the more important things for Addison's, and I feel like if you remember these points from Addison's, you probably get most of the questions right, or at least be able to recognize it in a vignette. So this is what I did. I took Addison and I made associations with each one of the letters from the name. So start with autoimmune disease, so you can remember that's an autoimmune disease. Again, that's the most common cause in the U.S. The D stands for drugs, so think of ketoconazole and rifampin. D stands for destruction of the adrenal gland, because you can actually have this Addison's take place from trauma or hemorrhage, even metastasis to the adrenal. So that's another one to remember, destruction of adrenal gland. I in Addison stands for infection, makes you think of HIV and TB. Remember, those are the most common causes in developing countries. S stands for skin changes, and that's the hyperpigmentation you'll see in the skin. In Addison's only, not in secondary, and that's due to the increased ACTH. And remember, Addison has an increased ACTH because the adrenal gland is not producing enough cortisol, so you're having an increased ACTH to try to compensate for that. And that increase in ACTH increases the melanin, and that's what's going to cause your hyperpigmentation, only seen in Addison. Also, you can see orthostatic hypotension. And then finally, decreased sodium, hyponatremia. This is all related to Addison, and this is how I remember it. I think this is a pretty good way to remember some of the key things about Addison's. Moving on to secondary. Secondary is going to be a lack of cortisol, but the aldosterone in Addison's that's deficient is actually okay in this situation, because the adrenals functioning fine is just not getting enough signal from the pituitary, the ACTH, to signal to produce enough cortisol. So the rest of the adrenal gland is working okay. So this is just a lack of cortisol in secondary. The pituitary gland is failing to produce sufficient levels of ACTH. The most common cause, and the most common cause overall, is going to be exogenous glucocorticoid use. So remember that. That's really important, and that may be in a vignette. I feel like that's a really important cause of secondary and overall the most common cause. So as far as the symptoms, you're going to see in both primary and secondary, you're going to see anorexia, nausea, vomiting, salt craving, hypoglycemia. This is all due to the lack of cortisol. The symptoms that you'll only see in only seen in Addison's, like we went over before, the hyperpigmentation due to the increased ACTH, and then also orthostatic hypotension, which is due to the decreased aldosterone. So these are only things that you'll see in Addison's. The labs you want to start with, your 8 a.m. ACTH. You do this in the morning because your ACTH is going to be, your cortisol is actually the highest in the morning. So ACTH responds accordingly. And so you take it in the first thing in the morning. It doesn't have to be exactly at 8 a.m., but it should be first thing in the morning. And then if you see an increased ACTH, you're going to be thinking primary, and then if it's decreased, you're going to be thinking secondary causes. So as far as screening labs to differentiate the two, um, you do a high dose ACTH, which is a cosinotropin test. And if you see no rise in the serum cortisol or little rise in the serum cortisol responding to the ACTH, you need to think primary. And again, remember, in primary, that's when the adrenal gland is not functioning properly. So it doesn't matter how much ACTH you give, or the synthetic version, which is the cosyntropin. It doesn't matter how much ACTH you give, the adrenal can't pump out any more cortisol because it's not working properly. Um, and that's in contrast to secondary, where in secondary, the adrenal gland's working fine. It's just not getting enough ACTH from the pituitary. So if you give ACTH in secondary, you're going to see a rise in serum cortisol because the adrenal's working fine. It's just not getting that signal. It's not getting enough ACTH. So that's an important thing to remember, and it'll help you remember it on the exam, as well. As far as treatment, hydrocortisone, you give in both. If so, in secondary, you only need hydrocortisone, but if it's primary, if it's Addison's, you need to give hydrocortisone and fludrocortisone, and you're giving the fludrocortisone because remember, there's a deficiency in the aldosterone as well. So you need that. The fludrocortisone is similar to aldosterone, and it's going to help regulate the BP, the sodium. But again, that's only in primary. Only in Addison will you give the fludrocortisone. If it's secondary, you only give hydrocortisone. Primary, you'll give hydrocortisone and fludrocortisone. Okay, so moving on. Now we're going to move on to Cushing syndrome, which is the opposite. Now in this case, we're going to have where we had too little cortisone before, now we're going to have a cortisol excess. So some of the causes of Cushing syndrome, again, most common cause overall is going to be glucocorticoid use. So long-term glucocorticoid use is going to be your most common cause. Remember that. That's very important. So in Cushing disease, not syndrome, Cushing disease, you're going to see an increased ACTH production from the pituitary due to either hyperplasia or adenoma. So the adenoma or the hyperplasia is going to be pumping out too much ACTH, which is going to cause an increase in the cortisol in the body, and that's in Cushing disease. And that's the primary cause. Now, if we're talking about secondary causes, you can have an ACTH producing tumor. Small cell lung cancer is known for this, and this is a big thing on the exams and on your EORs and everything. Remember this. This is important. Small cell lung cancers can produce that excess ACTH. You can also have adrenal tumors leading to increased cortisol. So as far as the patient presentation, I think we all kind of remember some of the common things with Cushing's. It's just one of those things that we don't forget. Obesity, hypertension, moon phases, striae, acanthosis nigricans, hyperpigmentation if there's an increased ACTH, like in a small cell lung cancer. So just so you can kind of remember why you see some of these things, like so for instance, the oily skin, the acne, the hirsutism, which is the increased facial hair and increased hair in women, those things are going to be due to the androgen excess that we'll see in Cushing syndrome. And as far as the acanthosis nigricans, we know that's due to an insulin resistance. And that's why we're seeing that, because this cortisol excess can cause type 2 diabetes and of course insulin resistance due to the excess cortisol. So we'll see that acanthosis nigricans. The hyperpigmentation, again, is just like we saw in Addison's, is due to the increased ACTH. And this is the picture I think we all kind of think about when we think of Cushing's, and that's the thin extremities, the abdominal striae, obesity, the facial hair on women, the moon face, the supraclavicular fat pads, poor wound healing. So this is kind of the visual you should have in your mind when you're thinking about this disease. As far as screening, this is what you'll do initially. You want to do, there's a few different ways to do it. You can either do a 24-hour urine-free cortisol. The idea is you just want to see do they have an excess cortisol? So you can start off with a couple different ways. You can do a 24-hour urine-free cortisol. You can do a nighttime salivary cortisol. And then you can also do a low dose overnight dexamethasone suppression test. The low dose overnight dexamethasone suppression test, you're going to give them dexamethasone 1 milligram before they go to bed. You wake up the next morning, you test their cortisol and see if there was an increase or no suppression at all in the cortisol levels. Then this would indicate that it's Cushing syndrome. So then once you screen and you see that they do indeed have a cortisol excess, you want to go ahead and differentiate what the potential etiology could be. So the ways that we do that, first we get their baseline ACTH, see if it's elevated or decreased. And then we go ahead and we do a high dose dexamethasone suppression test. So in this case, we give them a larger dose of the dexamethasone. And we again test the cortisol levels. And if it's Cushing disease, meaning that it's caused from the a pituitary problem, you're going to see an increased ACTH and you're going to see a suppression of cortisol. This is important to remember. Cushing's disease is the only etiology that will suppress with the high dose dexamethasone suppression test. None of the other ones will. This is the only one when you give that high dose dexamethasone suppression. When you give that high dose dexamethasone, that's going to suppress, the cortisol will suppress when you actually give that dexamethasone. So remember that only Cushing disease will suppress. If it's an ectopic ACTH producing tumor, of course the ACTH is going to be increased because it's producing that from the tumor, but there will be no suppression of cortisol. And then finally, if it's an adrenal tumor, you're going to show a decreased ACTH and no suppression of cortisol. So again, the only one suppressing is Cushing disease. And then if you really think about these, it'll make sense. And then when you're on exam, just try to focus and think about it. If you have an adrenal tumor, the tumor's secreting cortisol. So why would your ACTH be up? It wouldn't be because it's secreting cortisol, and ACTH is there to control cortisol. So if there's an excess of cortisol in the body, you're going to obviously have a decreased ACTH to try to compensate. Same thing if you have an ectopic ACTH producing tumor. Obviously, you're going to have an increased ACTH. So you just have to think them out. And if you can try to focus and remember this on the exams, it'll definitely help to differentiate for you. And then as far as the treatment, depending on what it is, if it's from exogenous steroid use, of course, you're going to do a gradual taper, get the patient off the steroids. Otherwise, it's pretty much cut it out, depending on where it's coming from. If it's Cushing disease, you can do a transsphenoidal resection, which is actually an incision made at the back of the nose, and then into the sphenoid sinus, directly into the cellulosic. It's actually pretty interesting. And rather than doing a craniotomy, this is a much less invasive way. So it's actually going right through the nose. They go through the nose, or even in some cases, right into the top of the lip. They can go through there. And I have a picture here to get an idea of the endoscope going right into the sphenoid there, into the sphenoid sinus, into the cellulosic. And this is a way they can actually remove the adenoma that's on the pituitary. So if it's an adrenal or ectopic tumor, of course, again, it's just a surgical removal. Ketoconazole can also be used with an ectopic tumor, and ketoconazole is going to help decrease some of the hormones that are being produced to help with that. But most of the cases with Cushing syndrome, it's basically just going to be cut it out. So moving on to hyperparathyroidism. So primary hyperparathyroidism is just going to be an increased PTH. So PTH is your parathyroid hormone. It regulates the serum calcium in the body. It acts on the bones, the kidneys, the intestine, helping either increase or decrease the amount of serum calcium in the body. So some of the causes, the most common cause by far of hyperparathyroidism, of primary hyperparathyroidism, is going to be a parathyroid adenoma. That's almost in all of the cases. And again, when you're taking your PANS, you're taking your exams, most of the time they're going to test you on the most common things. They're not going to be asking you about a patient it might be a patient taking lithium, that's possible too, but most of the time they're going to ask you about the most common things. And in this case, you need to think about a parathyroid adenoma. That's almost all the cases. So real life or the exams, think parathyroid adenoma when you see this. Another cause, again, like I was mentioning before, is lithium. And then also in men 1 and men 2A syndrome, this is one of the diseases you'll see as well. Men 1, of course, you see pituitary adenomas, pancreatic cancer, and hyperparathyroidism. 2A, you see the pheochromocytomas, and hyperparathyroidism, and one more, I believe. I can't remember offhand, but so that's something else to remember, that it does fall within these categories. But overall, the etiology, most common cause is going to be a parathyroid adenoma, so definitely remember that. As far as the patient presentation, so most patients are going to come into your office, are not going to have any symptoms. You're actually going to find this, incidentally, you're going to take their labs and you're going to see this high calcium level, and you're going to say, all right, let me get a PTH level. You'll see that's elevated as well. But most patients aren't going to come in with symptoms. But that doesn't mean, just because that's real life doesn't mean that you don't need to know certain things for the test. And when you see hyperparathyroidism, um, in a vignette, this is what you should think of: stones, bones, abdominal groans, and psychiatric moans. That's really important because that's something that I remember being tested on in school. And you really should know that, because there's certain things that hypercalcemia can cause, and this is the way you're going to remember them. So starting off with bones, something that can actually happen from the increased calcium in the body is something called osteitis fibrosa cystica, and this can cause pain in the bones. It's some growths that you'll see on X-ray. I believe they're called brown tumors. So that's where you get your bones from. As far as stones, obviously you have an increased calcium in the body. You're going to have increased kidney stones. So that's important to remember. You'll also see patients with abdominal groans, nausea, vomiting, constipation, this increased calcium. For some reason, I don't exactly know why, it does cause some of these symptoms. And then finally, psychiatric moans. You can have psychosis, lethargy, depression. The idea is that the increased calcium actually changes your monoamine metabolism in the central nervous system, and can actually alter your mood and cognition. It's not fully understood, but that's the idea behind it, why you see some of these patients with hyperparathyroidism with this psychosis in a lot of cases. So remember that. That's really important. Although most patients are going to be asymptomatic, this is definitely possible, something that you can see on presentation. And in the vignette, they could absolutely give you somebody who's depressed, has frequent kidney stones, and they're going to ask you, with this patient presentation, what is the most common treatment for this patient? And you need to know that this patient's actually presenting with hyperparathyroidism, and the treatment is going to be a parathyroidectomy. So again, they're going to, the vignettes sometimes can be tricky, so you need to remember these things. And then, of course, another thing that's important to remember is you can have decreased deep tendon reflexes in hyperparathyroidism. So moving on, as far as I'm sorry, just one sec, the diagnosis. So the diagnosis, the labs that you're going to find, this is important, is a triad of hypercalcemia, increased PTH, and decreased phosphate. So this makes sense because your PTH is going to control the calcium, the serum calcium in the body. So an increased PTH is obviously going to lead to increased calcium, so hypercalcemia. Now the phosphate, why do you have a decreased phosphate? Well, PTH and phosphate are actually inversely related. And the reason phosphate decreases when your PTH goes up is because increased PTH actually leads to decreased phosphate absorption in the kidney, so more is being excreted through the urine, so you have a decreased phosphate in the body. So that's just, to remember. Sometimes it makes it easier to remember why these things happen, and you don't forget it for the exams. Some other ways that we can test as well is a 24-hour urine calcium collection showing an increased urine calcium. And then as far as treatment, this is another one where you're just going to cut it out. Parathyroidectomy is going to be your most common treatment. And as far as, after you do the parathyroidectomy, you want to make sure you give them vitamin D, calcium supplementation post-parathyroidectomy, because those things can be deficient because you're taking out the things that control the calcium in the body. So you want to make sure you supplement those in the patients. And if a patient is not a surgical candidate, you can actually use something called cinacalcet, which inhibits the PTH. So what cinacalcet does is it actually increases the sensitivity of calcium sensing receptors in the body. So it actually tricks the body into thinking there's more calcium in the body than there actually is, because it's increasing the sensitivity of these receptors. So the body thinks there's more calcium because it's become more sensitive, and doing this actually decreases the PTH because the body thinks there's more calcium present than there actually is. So this is pretty much only in like an older patient, somebody who has a lot of comorbidities, that is not a surgical candidate. Otherwise, you're going to do a parathyroidectomy. In severe cases, somebody comes in symptomatic into the ER who has hypercalcemia from hyperparathyroidism. You're actually going to give them IV fluids and furosemide. And why you give furosemide is because furosemide actually flushes calcium from the body. You lose calcium when you take furosemide, and that's one of the things that you have to remember when you're giving somebody furosemide, is that they can actually have hypocalcemia. And let's see, so that's right. And so in severe case, what I was talking about before. All right, so last thing we're going to talk about today is going to be hypoparathyroidism. And what you should think of when you have somebody with hypoparathyroidism is somebody who just recently had a thyroidectomy, and all of a sudden they have this decreased calcium. We actually had, I remember, an OSCE with a patient who just had a thyroidectomy, and then all of a sudden they're having these different muscle spasms and symptoms, and it was actually due to the hypoparathyroidism causing hypocalcemia. So remember, the most common cause of hypoparathyroidism is going to be post-neck surgery, like a thyroidectomy. You can also have autoimmune destruction. Hashimoto's can cause it, but again, this is not as common. The most common is going to be that post-neck surgery. So as far as the patient presentation, you're going to have different presentations caused from this increased muscle contraction. So they may have perioral numbness. They may have, I'm not going to say this right, Vostek sign. I have no idea how to say that. Anyways, Vostek sign is when you tap somebody on the cheek and they actually have spasms in the cheek. Another one is a Trousseau sign, and that's going to be a carpopedal spasm. When you pump up the blood pressure cuff, their hand kind of points down. And this is a picture of both, so you can see. So the CH, whatever, that sign is when you tap the cheek and they have these spasms in the cheek. And then the Trousseau sign is going to be when you pump up the blood pressure cuff, their hand's actually going to have this this spasm. So that's what that looks like. Tetany in severe cases. As far as the diagnosis, again, just like in hyperparathyroidism, where you had hypercalcemia and an increased PTH, in this case, you're going to have hypocalcemia, decreased PTH, and increased phosphate, which again makes sense from what we talked about before. And just going back to the patient presentation, just so that can make a little bit more sense to you. So why are you having all these muscle contractions? What's going on in the body that you have this tetany, Trousseau sign, the perioral numbness? So the reasons you have all these things going on with the muscles is because when you have decreased calcium levels in the extracellular fluid, it actually leads to an increased permeability of your sodium ions, meaning they're getting into the cells easier, which leads to progressive depolarization and actually an increased action potential. So you're going to have all of these increased muscle spasms. So just kind of picture that in your mind, and it'll make more sense to you to understand the pathophysiology behind it. So in addition to the triad of hypocalcemia, decreased PTH, and increased phosphate, the EKGs are going to also show a prolonged QT interval, which is important. And then as far as treatment, it's pretty straightforward. You're basically going to give calcium, vitamin D supplementation. If it's a severe case where you're worrying about some arrhythmias, prolonged QT intervals you're seeing on the EKG, you might give them out IV calcium gluconate just to stabilize the myocardiocytes. The cardiac cells, and to stabilize the heart, so you don't have these these arrhythmias and things like that. So that's all I'm going to go over today for endo. I'll do another one in the next few days, starting to go over diabetes and some of the meds and things like that, which is going to be I'll probably focus on just that on the next video because that's a pretty long subject. So again, thank you. I'm going to be coming out with new videos every week. I'm going to try to do as many as I possibly can. And subscribe because I'll have more stuff coming out soon. Also check out my Instagram page, and I have a podcast that I just started up as well. The podcast is just going to be like real straight to the point, high yield stuff that you can listen to before a test just to really cram and get a lot of the knowledge in. And the Instagram, I'm posting a lot of mnemonics and things like that. So check out both of those, and thank you for watching the video.